Okay, I want to welcome everyone tonight to the webinar on current concepts in in the treatment of orthopedic infections and fracture-related infections. I'm joined today. I'm Michael Sirkin, and I'm joined today by Leah Katan and Arun in Asia to do this. And this is really what we really want to be doing, which is fishing, trick-or-treating, and hiking out in the mountains. But we're here today to discuss infections. We have some slides we have to take care of, some of the financial relationships that are that you can see here. AO North America is an independent, not-for-profit surgical specialty society that is dedicated to improving the care of patients by education, and we do not endorse or promote the use of any products or services of commercial entities, and there is no equipment being used in this course. All of your microphones and cameras have been turned off. You want to send all of your questions and technical issues through the question and answer box. If it's a technical issue, Chris O'Reilly, who's logged on, will answer for you, and questions will either answer live, or we may just answer the questions directly to you. This webinar will focus on the treatment of fracture-related infections. You will gain an understanding of the appropriate how to treat infections and when to retain implants. It'll also help you identify when the implants need to be removed, the importance of stability in the face of infection and treatment. It'll also discuss the techniques of making use of antibiotic rods and local block spacers, and discuss their roles in the treatment of orthopedic bone infections. And we'll do a brief introduction of what current research is being performed and a demonstration of the RIA 2 for the treatment of osteomyelitis. These are your learning objectives. At the end of the session, you should be able to identify how to treat osteomyelitis and retain implants, outline when it's time to change your tactic, list some of the key steps in the treatment, describe appropriate uses for both transport frames or block spacers in the treatment of bone defects and related to osteomyelitis, and define the local use of antibiotics. This is going to be our agenda for today. Remember the other webinars. All webinars are on Tuesday at 8 p.m. This is for the fellows, and distal humerus and pelvis will be the next two in October and November. And webinar Wednesday, the next one will be distal femur fractures, with John Scloraro being the moderator. Let's jump right into our course now. We're going to primarily do this by the use of cases and discuss what we would do. So this is a 67-year-old man who was hit while refereeing. He had a tibial plateau fracture, and now he's 2 weeks post-op, and he presents with a swollen knee and drainage from his wound. When you take a look at the x-ray, we can note the big thing here is potentially a malreduction and the fixation. We can see here the fixation, and we can see the CT. We can see air and soft tissues throughout all of the area on the CAT scan in the joint, as well as next to the plate, and even distal to the plate. We can see the extent of the infection. So again, what would your treatment options be for this in the 67-year-old with this malreduction, with this somewhat malreduction? So the options are pretty much always the same when we deal with these cases. It could be aspiration and antibiotics, surgical debridement only, debridement and revision internal fixation, or debridement and removal of external fixation. So the big question here is whether to revise this with the malunion. I think that at 2 weeks, if it was anatomically aligned, we probably would not have as good of a discussion around this issue. I'll ask Arun or Leah, what do you think real quick about this in a minute or two? Would you revise it, or would you just leave it the way it is? Arun?
Yeah, aesthetically, not great to look at, but we do know that the knee joint's got about 1 centimeter cartilage, and they've at least addressed the condylar widening. So in this case, it's 2 weeks out. I think I would kind of deal with the infection more so than anything else. Maybe leave the fixation construct in. Great.
I think there are some issues with revising this. My first gut instinct, if this was a 20-year-old guy who was just starting, I may consider revising this. But trying to revise a 60-year-old gentleman with, you don't know how hard it was to put back together. You could see on the CT scan some of the small pieces, and our option was we're going to leave the fixation alone for now and try to get him back and deal with things later. So we do an arthrotomy, and I do a medial arthrotomy instead of going and trying to wash out the joint through the incision that's used to put this plate in. It's very hard. It's submeniscal arthrotomies are typically done for this, and you don't usually get a good exposure to the joint. And I really want to wash out the septic arthritis and do an adequate joint rebridement, and then using the previous surgical wound to breed and do cultures. I think that's important to do all of those things, and that's what we did in this case. Some of the criteria to retain implants is they must be functioning and they have to be stable. I put this slide up so that you can see you have to test your implants. So you need to know what implants are in. Do you need a hex screwdriver? Do you need a star screwdriver? Do you need locking screws? Do you need regular screws? But you should test all of your implants. You might have to change a screw. If a screw's not functioning, you probably can need to get rid of it or change it, but you can leave the rest of the stuff there. And you need to be able to get access to the infection and must be able to be debrided. And this will come into play later, and I'll show you in another case, but this is the criteria to retain implants. When you do your debridement, you remove all of the dead tissues, take cultures, typically do an odd number, so a tie can go to someone. There can't be a tie in the number of positive and negatives, multiple sites. Use tissue samples. I like to scrub the plate with chlorhexidine scrub brush and irrigate it. And I typically do at least 2 debridements or washouts, especially when there's purulence present. The use of local antibiotics. I prefer absorbable beads because, especially if you're going in to just try to treat an infection and let the fracture heal, and I use calcium sulfate. And the 2 most commonly ones available are Stimulan and Osteoset. You can figure out how to use them. And I use tobramycin and vancomycin, and they make beads. Personally, I like to have good soft tissue coverage around them, either under muscle or inside of bone. Mike McKee had a paper out showing that there was drainage and it was okay, but it just doesn't feel right to me to get the soft tissue envelope to really seal. And so I tend not to put it in areas of subcutaneous bone or when there's not good soft tissue. And in those cases, I just use powder. And Arun's going to talk a little bit about powder and antibiotics in wounds later. And repeat debridements. I said I usually do at least 2 when there's purulence. You saw the extent of the infection to here. His cultures were MRSA. Debridement, IV vancomycin, and then vancomycin directly in the wound because there was not good soft tissue in this older gentleman. Here he is at 8 weeks, status post-IND. No, I did not change the reduction. It's just projectional. You can kind of see that his tibial plateau view, which is what this is, and the other one was more of an AP, looks a little bit better. You can see right here, though, you can see the malalignment, and when you tilt this on end, it looks worse. And here he is 1 year later, post-op, and he's refereeing back to football, and his implants haven't really come out yet. So I want you to, so the thought process of an acute infection with a fracture is to control the infection, try to get the fracture to heal, and then remove the implants as needed. Take this 22-year-old gentleman, similar type, but this is a 22-year-old. I think this becomes a little easier for a discussion because I think we like this reduction a little bit better, but he presents with very similar findings at 3 weeks, post-op swelling, large effusion. He was aspirated in someone's clinic, so we know he has pan-sensitive staph, but he has a large effusion. His white cell count in that fluid is 120,000, elevated sed rate, white cell count, and CRP. So our treatment options are the same. And in this case, it's a little bit clearer, I think, that it's 3 weeks and we want to go ahead and just try to maintain the infection, maintain the hardware, and treat the infection. Same approach, medial parapatellar approach and a lateral approach to the plate. And here I've outlined the calcium sulfate beads because his soft tissue is good. Keep an eye on this anchor because this is going to come into play later. So here he is, 6 weeks, he's healing, beads are resorbed. 6 months later, he presents with the exact same symptoms. Large effusion, white count, elevated CRP, and white count. And you see what happened is that we probably never eradicated the infection as we did in the last case. And it's probably because of all the braided suture material. Look at the defect that has been created by the suture anchor here. But now our fracture's healed and we can go ahead and just and do our debridement, take our hardware out, fill the defect with calcium sulfate. And here he is 5 months after his infection. Still unclear what will happen with the joint totally, but there is cartilage there, as Arun talked about. And he has minimal pain. He's running, or he's not running, but he's doing gym exercises. So again, same thought process. And this time we had to remove the implants. So now I want to take you to another case where we have a 61-year-old man who has an open tibia fracture, not fully cleared on night 1, had something done temporizing and a fasciotomy done. Taken to the operating room on day 4, had his intramedullary nail placed. He presents now at 10 weeks, pain, swelling, red and warm, sed-rate CRP, and draining pus from his open wound. So here's a representative CT scans of his leg, and you can see what's going on here. So your treatment options again are a washout alone, or this time you can remove your implants. You could do an exchange nail, an antibiotic nail, or an external fixator. Leah, what do you think?
I am a fan of removing hardware. I would do an antibiotic nail here.
Okay. So I elected, and I'll show you why, cultures IND, Vanco placed into the wound because it was on the medial face of the tibia, no soft tissue, wound closure with skin vac, and he was discharged day 5 with group B strep. The logic for me at this point was he's 10 weeks out and he's trying to heal the fracture. And you can see the callus that's around his fracture site. He's actually really trying to heal this. And so trying for suppression and fracture healing seems like a good idea to me, and remove the implant later if needed after healed. But 10 days later, he comes back with the same symptoms. And now he has a large local abscess and he has a pus from his anterior defect around the nail. So now we're seeing pus in the intramedullary canal, which we didn't. Again, same treatment options. Whoops, I don't know what happened there. Nope, okay. I'm not gonna, I have a big X to wash out alone and retain the implant because that's the definition of insanity. I don't know why it's, there it goes. I don't know why it didn't go the first time. So these are our 3 different options. I'm gonna show you. Oh, I know why. So I want you to look at this CAT scan. This is the original CAT scan from day 1, okay? Let's see, okay. And what you'll see here is you'll see that there's air inside of the intramedullary canal. So remember I put that you had to be able to adequately debride this. So I think this is a failure on my part of actually seeing that I wasn't going to be able to adequately debride this because there's air in the canal, which means in the center of the nail. So that means that there's something going on there. And so that was a failure to correctly diagnose probably the extent of the osteomyelitis and the infection. And Leah was, I think, absolutely correct. We're not going to do that. We're going to take out the treatment plan. We're going to take out the nail. We're going to debride with the RIA. We're going to irrigate intramedullary. We're going to get stability with an antibiotic rod and treat the fracture later. And here you see the use of using the RIA, and we'll show this again, but watch, you're going in and out motion, and you want the tube here to clear of the bone and the infection and everything, and it's collected. And the reason you'll do this even when you're using it for bone grafting, but you want to make sure that this tube clears, or you're just going to be reaming and you're not going to be irrigating and sucking out. You can also go ahead and take out the drive shaft and then use it to irrigate out your canal. This is actually a RIA 1, and you want to see this in the upper right hand corner, which is fluid coming out from the your distal locking screw, so you know that you're actually irrigating out the entire canal. Oh, sorry. Antibiotic rods, they're good for intramedullary use. You can make them on a reaming guide wire. You can make them on an external fixator or threaded rod, may provide enough stability to avoid X-fix. This is the YouTube channel where you can find it on AO Trauma North America. I'm going to put this into the question and answer, and I have a QR code where you can download it. Here you see the antibiotic rod going into place. Here he is at 4 months off antibiotics. Cultures are negative. and then treat the non-union in any way you think better. And in this case, it's an intramedullary now.
Rewarding as you think.
So you can retain your implants in the face of infection. They must be functioning and provide stability, adequately debride, local antibiotics when possible, systemic antibiotics, and remove your implants if needed. Those are some of my cases. So I want to now move on to bringing Arun up, and he's going to talk to us about one way of managing bone loss due to osteomyelitis.
All right, I'm gonna go in full mode. That's pretty good, Dr. Sergen. Love the video, and the timing was pretty good too. So let's start with this case. So we've got a 32-year-old female, status post MVC. She's got a right open distal tibia and fibula fracture. Medical history-wise, she's pretty healthy. She is a heavy alcoholic. The family kind of mentions that. The wound is obviously distal medial aspect of the leg, 5 by 3 centimeters. So this happens on a Sunday. One of my partners, actually in this case, is one of the trauma fellows, took it to the OR for IND, X-fix, and then they put this nice cute little plate on, thinking that it would help us with the definitive fixation as well as stability. And so this is what the construct looks like after the IND and X-fix. And I don't know if this projects well, but we'll see it. But the plate, again, was applied to the medial wound. They get a post-op CT scan, and you can see the intra-articular extension based on the CT scan. So, you know, we could do a whole little debate about nail versus plate, but I didn't feel too bold at the time, so I can tell you what I did. I went ahead and plated this. So 5 days later, I take it back to the OR for definitive treatment and put some lag screws to the joint, screwed for the fibula, and then definitive anterolateral plate. And here you can kind of see again, I've taken away that cute little provisional plate that they placed. So this is 5 days later, and patient's doing well overall, wounds healed on the medial side, and she comes back to clinic at about 3 months. And at this stage, I really have to go ahead and let her start weight bearing. So this is 3 months post-op when we initiate full weight bearing. And then here's where it comes back. 6 months later, she comes back to clinic. She's like, hey, this doesn't feel right, doesn't look right, and it still hurts. And what you can see is catastrophic failure of my fixation construct. So Leah, we've been doing pretty good on time. So what do you think? What would you do in this case? This comes back to your clinic.
Yeah, so this is a combination of infection and catastrophic failure. And so I would say that there's no more stability, going back to Mike's talk. So these implants have to come out, and you have to treat the infection and reestablish stability, either with external fixation or revision of the internal fixation or some sort of temporizing device. And I really like local antibiotics and some flavor.
Yeah, that's pretty much what we did. The same sort of theme that Dr. Sergen hit on. So for me, these hardwares are no longer providing stability. So I'm going to remove this hardware. I'm going to go ahead and get cultures because it's nice to have speciation and have a good organism. So the infectious disease doctor don't get angry with me, as well as we treat the appropriate bug. And then doing an adequate debridement. And this is going to sort of get into some of the discussions we'll have about what exactly is adequate debridement. And then once I remove the hardware, we all know that we need to provide some sort of fracture stability, because that provides a better biological environment, because instability only propagates infection. And then I love the topic of local antibiotics. I think that's extremely powerful and useful, especially with some of the limitations of IV antibiotics, particularly in an area that's been previously traumatized. The big question is to do this in a single stage versus multiple stage. Leah, you mentioned the case of an antibiotic coated rod. I really like, in those cases, a single stage, but we'll kind of talk about when to do multiple stages. So here's what I did. And again, you guys can critique this or tell me if you do anything differently. But for me, the first thing was debridement. I had to get rid of all the infected and dead bone. And so for me, the best way to establish what's dead is to actually let down the tourniquet and go ahead and get a burr and kind of look for that paprika sign and see what's viable and what's not viable. In this case, not much was bleeding. And so I did an extensive amount of debridement and got all the dead bacteria as well as dead bone out. I got cultures grew out, and 2 weeks later, we know it's MRSA. In reality, we actually knew 4 weeks later, but we just waited longer term. And then I went ahead and cannulated the distal tibia with all this sclerotic bone. I felt that it was really important to establish the intramedullary canal, not only to get the endosteal blood flow going, but also for my definitive implant treatment. And Leah, I did exactly what you recommended, placing an antibiotic cement spacer. And then the way I decided to provide stability, though not the most stable construct, was to put it provisionally in an X-fix. That way, I kind of didn't do any more sort of biologic insults, and I could just place the X-fix on. And then, if you remember, I mentioned the fact that the patient was alcoholic. I really think that we really need to do a better job at discussing nutritional optimization. In this case, for me, in patients that are morbidly obese or anyone where I'm worried about their nutrition status, checking those labs of transferrin, ferritin, all those things that are pre-albumin, albumin are extremely important. And I think really getting the host as well prepped as possible is extremely important. Dr. Serkin, would you have done anything differently? What do you think?
I think this is a great option. X-fix and an antibiotic spacer makes a whole lot of sense. It's stable. You look like you've done a pretty good job of incorporating your spacer around the bone, both anteriorly. I can see on the proximal part of the shaft, you're overlapping there, and distally. The only other thing I would have considered was maybe using an antibiotic rod and then putting the cement spacer around that. The trick to that is you really have to be careful because the cement can rebond to itself. So you have to be careful and really keep irrigating that out. And I just like intramedullary nails, antibiotic rods, better than X-fix because I think it makes your soft tissue envelope more pristine and not communicating to the outside world when you go back in. But other than that, I think this is good. You have the stability that you need via an X-fix. You can also use a plate if you want to do an antibiotic covered plate, which is becoming a little bit in fad. But the principles of debridement, stability, and dead space management have all been followed.
Yeah, that's a perfect segue to the next slide about the cement spacer placement. This is, again, a slide courtesy of Dr. Serkin, but you can see a very good application of the cement spacer. You've got malleables, sort of protecting the posterior soft tissue as well as giving you good cement posteriorly for that nice pseudomembrane. You've got bridging of the cement over the cortex of the bone, again, just to give you the nice pseudomembrane formation. And then you've got irrigation, cooling. Keep in mind, this is very much an exothermic reaction, so we don't want it to burn the surrounding tissue, particularly the neurovascular structure. So it's really imperative to kind of cool this. And then you can see that methylene blue has been injected. It obviously helps to when it's time to be removed, you want to make sure you get all that blue. The other thing to use is, some commercial cements such as Palicos come green. So, but these are nice little tricks. So 2 weeks later, obviously we staged that, and X-fix was the provisional. Once we've got speciation, I take the patient back. I get bone graft, a reamer irrigator aspirator from the ipsilateral femur, mix it, kind of expand it with some Kensel's bone grafts. I go ahead and do a fibular osteotomy. I feel that kind of frees up the limb a little bit better to help me control, sort of the alignment. And then I decide the definitive treatment is going to be a nail. However, it is nice that I have this provisional plate on, and I think for these metaphyseal regions, it's nice to have that additional stability. So I incorporate and leave that plate in, and then I place all the bone graft after taking out the cement spacer. So these are post-ops, obviously not great. The sagittal plane, you can see I've got a little bit of an apex anterior, but I decide to go ahead and take that. Leah, Dr. Serkin, any comments? Anything differently you guys would do? What do you think?
I think this looks really good. I'm with you. I like the plate. I think especially with a short metaphyseal segment like that, the nail isn't going to control it quite as well. So I think this looks good, perfect for mescaline.
I don't have anything to add. I agree. I think in these metaphyseal regions, the more stability you get, the better the mescaline and the better the bone graft incorporates by the stiffness that you are generating. You want no motion here. It's a little different than an intramedullary nail treated for a fracture with a defect. And I like the plate because it's like now, once you get your alignment, it actually helps with putting your nail in, because these can be difficult to align.
Yeah, and sure enough, I'll kind of go through sort of how this turns out. But question about how much do you debride, and I think this really kind of leads up to what Dr. Guiton is going to talk about with some of her research updates. But it's very much for us, it's very much like a visual thing where we're kind of burring and taking bone back, and it often depends on what the patient's blood pressure is, what we see bleeding. So for me, it's a paprika sign, but I think Dr. Guiton is going to really kind of break it down. And then deciding between single stage versus multiple stages, I think we talked about this briefly. For me, anyone that's got sort of a chronic infection, or if it's going to be a very long, elaborate surgery, I'm usually thinking about staging it. The nice thing about staging is I can get data on speciation of the bacteria. And for me, the single stages are usually when I'm doing some sort of antibiotic coated rod for those sort of procedures. Before doing this, I did make sure I looked up the literature on masculine technique and what the rate of success is. I found that there hadn't been much literature on tibias, isolated tibias. All the literature that was presented was on humeruses, femurs, and tibias. And so what we did was, with Dr. Guiton's help, we did a systematic review, and we showed that actually when you compiled all the data, even though it was level 4 data, the masculine technique in the tibia had about an 84% pooled success rate, and the size of defect didn't matter as long as you got that region clean. So with knowing that, I felt very comfortable doing masculine technique, and I can tell you this is what happened. This is 3 months later. You can see sort of consolidation. And then this is 6 months later. So you got good healing. And the nice thing is, if you look at this progression, you can almost see that, every single fracture surgery is erased, where you want the fracture to heal before your implant fails. And if you pay careful scrutiny, you can see that one of the proximal screws in that plate is backing out a little bit. So fortunately, the implants lasted long enough to get the fracture to heal, and the patient went on to do well. So with that, I'll go to my summary slide. Right now, my FEP educator is just like having a heart attack and just knowing the number of words I put in the slide, but it just follow me. So I think we're all saying the same things. For any sort of osteomyelitis, the first question is removing the hardware or retaining it. Obviously, if it's providing you fracture stability, and if there's a possibility of the fracture to heal, you want to retain it. In this case, there was catastrophic failure, so it was not doing what it needed to do. So it was easy to remove the hardware. Getting cultures is nice for speciation data. It helps with targeting the IV antibiotics. And then the quantity and quality of debridement is critical. And we're going to have Dr. Guiton explain about how she scientifically decides on the quantity of debridement. Fracture stability, we already talked about. And then the role of local antibiotics. I found this to be extremely important. I'm going to be discussing a lot of this in my research updates section in a little while. And then next question is between single stage and multiple stages. For me, again, when I'm doing multiple stages, it's often based on the extent of bone debridement, the extent of surgery, my level of fatigue, if the amount of surgery the patient's had, all these sort of things, as well as the chronicity of infection. In data, or in cases where I really need data on speciation, it's very, very beneficial to do multiple stages as opposed to doing a single stage. And then hopefully with this case, I've kind of elucidated that the masculine technique is a pretty efficacious tool for segmental bone defect, even in the distal tibia. And then we talked about how to adequately place the cement spacer. And then whenever I do the masculine technique, there has been literature showing that it tends to be more successful when used with intramedullary nails and femurs and tibias. But in cases where there's a significant region of the metaphysis, I find this supplemental provisional, whether it's provisional or definitive plate, to be very, very beneficial, not only for maintaining my reduction like Dr. Serkin was talking about, but also maybe providing a better strain. We talk about for distal femurs and nail plate combos, so, why not nail plate combos for tibias also in this case? And it turned out to be pretty well. So with that, unless there's any critiques or comments, I'm going to stop sharing. And
That was really good, Arun. There's one question here that I'll throw out. I'll let you guys answer and then I'll give my opinion. It says, how much weight do you allow patients to apply during an antibiotic coated rod?
yeah, I let them immediately weight bear. That's the benefit of the antibiotic coated rod. A lot of times, whenever I place the antibiotic coated rod, not only, is the benefit the local delivery antibiotics, but you often have to ream up. I almost ream up to a size 14, 15, which kind of feels very scary and concerning in the tibia. But if I'm using that Tygon tubing and placing the antibiotic coated rod, I'm letting these patients immediately weight bear.
And Arun, you're using a standard interlocking nail that is coated in antibiotics as opposed to me that's using a threaded rod, right? Because I make mine on a threaded Alizaroff rod.
Correct.
Yeah,
Leah?
I do, Mike. I do the same as you. I make my antibiotic nails on a threaded Alizaroff rod with that same hook. So I do it very similarly. And for me, it depends on where the fracture is in healing, because you don't get length stability or rotational stability with that antibiotic rod necessarily. And so it kind of depends on the fracture for me. If the fracture is far along on the pathway to healing, I might be a little bit more liberal, but I tend to, especially in younger patients, geriatric patients are a whole different thing, but I tend to protect them a little bit more.
So that I do the same thing. And what I do is so typically there's bony contact. So once fractures have to require their nail to come out, they're usually rotationally stable. Usually the fibula is healed. So the rotation in a non-locked rod is not a big deal. If there's a gap, then I'm typically putting an antibiotic spacer in there. And the way I put it in, it's actually a bone substitute. And so that you can load on that. So what I typically do is go ahead and let everybody weight bear. I might put them in a fracture brace for a tibia, nothing for a femur, even with a rod such as what I use most of the time. If it's unstable, I actually may add a 2-pin X fix. There's a question about transport. That's going to be the whole next topic. I think that's what Arun just probably answered the person. And so now I want to bring Leah up and have her talk about another way of dealing with defects as it relates to infection. And please keep using the questions, which people are now getting more comfortable with.
Sorry, I was muted. Yeah, definitely keep the questions going. So I'm gonna also start this one with a case. So I have a 27-year-old male, had a motorcycle accident, went to another hospital with an open tibia fracture where he underwent IND, intramedullary nail, and VAC placement. And he had been undergoing home VAC changes for about a month prior to presenting to our plastic surgery clinic because he noticed a foul odor and escalating pain and purulent drainage, and he was kind of like writhing in the clinic. I was impressed that he had lasted that long. And so this is what his leg looked like when he showed up to clinic. He had this nail in that, is reasonable, but he had a VAC basically overlying a bunch of dead bone that you can see here. And it's a little bit hard to tell from the picture, but although the muscle looks healthy, the bone looks entirely dead and it was pouring out pus. You could see the nail kind of through this gap and it really just kind of smelled like roadkill. And so options here, we've talked a lot about hardware retention versus hardware removal, but in this more subacute / not quite chronic, but 4 weeks of this kind of open to the outside air and open to VAC changes, I don't think, for me, keeping hardware in place in that setting, even if it has maintained its stability, is not an option. We know that we can't get rid of biofilm from implants or bone, much less, but much worse for implants. And so for me, maintaining the hardware is not really an option. And so he has a couple of problems. He has an infection, he's got a bunch of dead bone, he's got an unhealed fracture, and he has a big soft tissue defect. And so I like to think about all those different problems separately and address them kind of in the order of operations. And so for me, the number one problem to address is treating his infection, and dead bone kind of goes along with treating the infection. Second order of events is cover the soft tissue and get good, adequate soft tissue coverage. And the third order of events is reconstruct the fracture or the bone defect that he will have. And so, in order to address that first problem, treating the infection, We took him to the operating room. We did an extensive debridement. He had a bunch of foul smelling soft bone. We took the hardware out. Like we've heard a bunch of times already, cultures are super important to help our ID folks and us to choose the right, both local and systemic antibiotics. We debrided back to healthy bleeding bone, used local antibiotics in 2 forms. We had this antibiotic cement spacer and also antibiotic beads, and then systemic directed antibiotics. He grew multi-polymicrobial infection with beta hemolytic stress, strep, enterococcus, enterobacter, and prevotella. And he was started on 6 weeks of IV Zosyn, was what our ID folks selected for him. You know, once we kind of get that nice and clean and we're happy with that wound, the second problem we're solving is a soft tissue coverage problem that we often need help from our plastic surgery colleagues. And so he got a lot of debridements. He got 4 debridements and bead exchanges and spacer exchanges, and then he got an ALT flap, an anterolateral thigh flap, free flap with plastic surgery, so nice durable soft tissue coverage. And I'm gonna pause a little bit here. I think we're doing okay on time still. We've talked a bit about how do you tell how much to debride. I think this is an ongoing problem that a lot of people face. It's really hard to tell. We all talk about things like the paprika sign, which is when you start to see blood coming through the bone. But it's still pretty rudimentary. Those types of methods are pretty rudimentary, that we kind of keep burrowing back until we see bone bleed. That is also what I do in the operating room, but like Aaron mentioned, I'm going to talk a little bit about some new approaches to that. But we do think that the quality of debridement is absolutely critical. So you have to do a thorough debridement or you'll never get rid of the infection, because if there's not good blood flow, your antibiotics and your immune cells will never get there to treat the infection. With regards to my second, intraoperative challenges, how do you decide when it's clean enough and when it doesn't need any additional debridements? And I'd like to get other people's opinions. Mike and Aaron, what do you guys do? How do you tell when it's time to stop debriding and move on to the next step?
Well, like I said, if it's purulent, if I see pus, I definitely do at least 2. The last debridement is usually the shower, right? A debridement's not a shower of the soft tissue. It's a debridement. It's cutting away tissue. And so I try to do a good job on the first time, knowing that I can always reconstruct bone. I'm not afraid of that. That's one of the failures, right? Is people are afraid that they can't reconstruct things. And so you got to take away that. And so if I don't see any purulent material, if I don't see any more dead tissue on the, is when I do it. Typically it's 2 most often, sometimes 3, because I've gotten pretty good over the years of doing an adequate debridement once. But sometimes it's just like the one you had that had been exposed for a long time. You keep coming back, you keep smelling bad stuff, and you keep debriding. And sometimes you got to just pull the trigger and say, okay, there's not much else I have.
Yeah, I second that. I feel like it's very much an art. There's no good scientific data. In cases where I am bringing it back to put bone graft in, and it's been a extensive amount of time, such as 4 to 6 weeks later or 2 weeks later, I do send some frozen PMNs per half power field. But I got to be honest, almost all the time they've been negative, and sometimes I wonder about my bias and where I'm sampling from and all those sort of things.
I've known people that keep debriding until cultures are negative. Is that something that either of you ascribe to? No. Cool.
Remember, you're not really trying to sterilize the bone. You're trying to get the counts down to 10 to the 5th, and so that the body and antibiotics can kind of fight it. So I don't believe in serial cultures. Some people believe in them. It just hasn't. I don't have the facility to do it, and it's not borne out.
Got it. Cool. So for him, just moving on to sort of step 3 in his treatment protocols, reconstruction. So now, he's a 27-year-old gentleman now with a 5-centimeter segmental defect and a polymicrobial infection. And so we've already talked about one of these options. Aaron gave a really nice masquerade case where we used stage 1 with the antibiotic cement spacer and stage 2 with bone graft. And that's pretty effective particularly in the femur. And as we looked at in that systematic review, also reasonably effective in the tibia. Bone transport is an option. We're going to talk about that now. And then the third is a free fibula. And I guess we're in an orthopedic course. And so most of us aren't doing free fibulas. That's sort of a plastic surgery thing. And we all have had experiences of that failing. And so we definitely focused a lot more on masculine versus bone transport in these segmental defect cases. So just to briefly review what bone transport is, it's based off of the concept of distraction osteogenesis. And so you have a big hole distally here in this drawing. And the way it works is you make a osteotomy using very careful soft tissue, very, very careful preservation methods to maintain the health of the bone more proximally. And then over the course of time, you slowly move this middle segment south or distally into that hole. And you move it slow enough that the patient develops callus, or we call it regenerate, up proximally at that osteotomy site. And you kind of stretch it over time, and the regenerate kind of continues to fill in and heal. And it's a very effective and reliable way to fill a big segmental defect. But the downsides are that it does require the patients to participate. And so you need a patient that is going to be able to effectively kind of follow a prescription, because people can also end up with really wonky looking limbs if they do it wrong. Just to briefly talk about some tips and tricks and the basics of bone transport, the most important thing I would say is to keep it as simple as possible, mostly for our patients, because I think that it can be, in the context of an infection and a trauma, things can be very challenging for them to follow complicated treatment protocols. And if you keep everything lined up square and simple, the transport ends up being much simpler. And it's just some basic tenets. You really want to ensure that the bone is well aligned so that you can do your transport in one plane, just proximal to distal or distal to proximal, as opposed to having to do some sort of multiplanar correction. When I'm doing these in the operating room, I pre-build the frames, and you need those 3 rings. I like having a pre-built frame because it helps me keep everything lined up. And once you get the ring parallel to the knee joint, everything else kind of is nice and square and parallel. You can use several different flavors of ways to connect those rings. I think it's easiest to use clickers or transport struts, but you can also use hexapod struts depending on how much control you want versus patient factors. So adding a hexapod setup adds a little bit of complexity for patients, but gives you some sort of multiplanar control. I think it's really important to have 3 to 4 points of fixation per ring. I think you really need 3, but you can expect at least 1 to get a pin site infection, and you want to have the opportunity to pull a pin in clinic as opposed to having to take them back to the operating room to revise a ring. So I always try to have at least 1 extra. Because these frames are going to be on for a long time, I always use HA coated half pins or tension wires, and you want to put because these all have to be in for a long time, you want to do very soft tissue and bone friendly ways of putting them in. So make sure your drill bit is cooled, you place the pins in by hand, you don't want to burn bone, those sorts of things. I always include the foot while doing transport, because sometimes they end up with it. If you don't, they're at risk of an equinus contracture. When you're making your osteotomy, you also want to do it in sort of a very bone friendly way, so you don't injure the bone. That's where your regenerate is. And so make sure, again, use a cool drill bit, make a bunch of drill holes, and then finish it with an osteotome. And in general, you can get about 1 millimeter per day. I often start a little bit slower to make sure that they develop a good regenerate at the beginning, and then speed it up to 1 millimeter a day. And then I usually split it into 2 BID, so like 0.5 millimeter BID. And these fluoro images are just in the operating room. When you make your osteotomy, you always want to make sure that your osteotomy is complete and not tethered. So you kind of move it back and forth a little bit. But when you think about a 5 centimeter defect at 1 millimeter a day, you're talking about 50 days of transport for this patient. And so when you're talking to patients, you need to be really clear on what the plan is and whether that's something they're going to be able to do. There are several ways to put a frame together. Like I said, the simplest is to use the transport struts or clickers, and those are basically a form of threaded rods, and they can move things just in one axial plane. This is not the patient that I initially presented. This is a different patient, but we use transport struts here, and this is what that looked like at the end with the regenerate up proximally. Getting back to the original patient, we ended up using hexapod struts here because there was a bit of a multiplanar issue because the osteotomy tethered a little bit. But this is where that patient started. And then if you follow over time, you can see that this gap proximally gets smaller and the gap distally kind of gets bigger. There wasn't great regenerate at the beginning. He didn't get good regenerate actually until I finally convinced him to quit smoking. And then he kind of made regenerate like gangbusters. And so that was really, I'm now a believer in smoking for bone transport patients. They have to really stop smoking. And so this is the end of his transport. In terms of, I wanted to ask, Mike, I know you do a lot of these. Do you convert to a nail or do you allow them to consolidate in a frame?
I think it's better to, if you think you have a good handle on the infection, if you can convert them to a nail or even transport them over a nail, you get the frames off a whole lot quicker, more reliable healing, and they're not tethered to that frame for probably twice as long as it took to do your transport. If you're lucky, twice as long. It can be much longer. So I think a good option is to convert them to a nail or even transport them over the nail as we get more experience.
Yeah, I agree. I used to worry a lot about putting hardware back into a place that was infected. But like you said, if you're allowing them to consolidate in the frame, so this guy, minimum 50 days of transport and then 100 days of consolidating in the frame is what I would tell them. So 150 days in the frame versus 50 days in the frame makes a big difference to our patients. So anyway, this guy, he did consolidate in the frame. So this is what his limb looked like at the end. Just to show a different example, this is a guy who had a distal defect. This was his transport and he got a nail at the end and he was very, very happy. And so I'm with you, Mike. I do this predominantly now. I do the transport and then put a nail in kind of at the end of the transport, and that works really, really well. So just to briefly plug some things coming down the pike. There are transport nails out there that may allow us to be able to do bone transport without having to put people in frames, and the patients really love that. Today, you can use plate assisted transport with a lengthening nail, and this is all kind of predicated on making sure you have good control of the infection. The nice thing about a frame is that it allows you to not have hardware at the fracture site. Computer driven struts, I think, are coming down the pike from a couple of companies, and having had patients have all sorts of complicated following direction challenges, I guess I'll phrase it as, having a computer that we can program to do it would be very, very nice. And so with some of these things, it's possible that some of our complications will be reduced or eliminated, and maybe we might not need frames in the future. So just to quickly review takeaways, I think we've talked about this a lot, but the most important part of treating an infection is a thorough debridement. That's really, really critical. And there's several ways we talked about that you can tell if your debridement is thorough. It is, like Erin said, it's a bit of an art. It's not totally a science today, but that is the most important part of treating infection. Bone transport is a very reliable way to fill a defect. And in my hands, in the tibia, bone transport has been way more effective for me than Mascolay in the tibia, for whatever it's worth. Patient selection is super important. So I had a patient that went to jail with their frame, and that was a bit unfortunate. That kind of threw a wrench into our whole plan. But making sure that they're going to be able to kind of do their BID, 2.5 months of transport clicking is super important. And then when constructing the frame, make sure to keep it as simple as possible, because there's all sorts, you can make things super complex if you wanted to, both from a patient and a care standpoint, but I think it's important to keep it simple. I'm going to turn it back over to Mike.
So Leah, the question is how soon after docking do you remove your frame and convert to a nail?
I go pretty soon. I give it a couple of weeks. But I have had pretty good success with, finishing the transport and a couple of weeks later converting it to a nail. You want to be a little bit careful about the regenerate side because it's not super solid, but it can definitely be done.
Yeah, it can spring back, and so some people will put a hole in their nail so that they can put a screw into that. They'll even put an X-Fix on to stop it from springing back while you do it. It's technically just some things to stop it from springing back. There was another question here that Arun answered, but I'd like to know, I'd like to answer it out loud. And that is do you confirm your organism before you put a block spacer in?
Yeah, that's
Sorry, go ahead.
Oh, I was gonna say, that's a really interesting question. For the first debridement, no, because you just don't know at that stage. But once you do know, I do tailor my antibiotics to the bug. You know, you can put all sorts of stuff in there. Like I was recently had an antibiotic cement spacer with amphotericin B. It makes it yellow. It's kind of a funny color. But you can, not all antibiotics can go into cement, but a lot can.
Yeah, you have to use liposomal amphotericin B if you get a fungus. And so that's why. And so I do the same thing as you do, Leah, my first debridement. So when I do these patients, I do my second debridement at 5 days so that I have the results, I have the sensitivities. 99.9 times out of 100, it's, for me, it's Vancomycin. Some people are doing some other things as well. It's just kind of what works. But I do get organism sensitive. I think, Arun, go ahead.
Yeah, I agree with everything you guys have been saying. I usually do Vanc, Tobra, and Gent, and I've been studying, like patients' lab results to see if there's any AKI or anything like that. And as long as you do it locally, I haven't seen any adverse events. The question is whether it impairs bone healing, but again, it's very temporary. So I'm with you guys. I do broad spectrum first, and then if any of the fungus come back, then I have to think of some heat stable antifungal.
Okay, great. And then the other question is how long do you normally wait for your second stage of the mescaline, going from antibiotic spacer to your definitive bone grafting?
Yeah, so again, I think I answered this. So in non-infectious cases, I obviously want to wait somewhere between 4 to 8 weeks. That's usually when the pseudomembrane's richest with all the growth factors, usually about 6 weeks at that point. However, in the case that I demonstrated, for me, it was more so to get speciation. So in that case, for infection cases, I might pull the trigger a little bit sooner. So in that case, I only did 2 weeks. And obviously the pseudomembrane wasn't as good, but it's still incorporated in healed bone.
Yeah, if you look at the research behind it, it says that your highest osteogenic potentials in the membrane are between 4 and 6 weeks, and that was done in sheep. Seems to be a little bit longer in humans, we think. And so the key for me is when the soft tissue is ready to go, and it's typically more than that. I also do a biopsy to make sure that I have treated the infections appropriately, and then I'll do my bone grafting. I'm not sure that's necessary, but that's what I do. It works in my hands, and some people do it and some people don't. So I think it's around, it's what you think is good, but it's typically most likely related to your soft tissue when your soft tissue envelope is ready. If your soft tissue envelope is not ready, don't do it, just wait, and the membrane will still work. So with that, we're going to move ahead to research. I'm going to bring up Leah and have her tell us what's coming down the pipeline for debridement that maybe help some of us that aren't as good as you all to breed.
Yeah, so I'm gonna, oh yeah, I'm not muted, great. I'm going to talk briefly about some work that we're doing on helping on applying some guidance principles or surgical guidance principles to help us do a better job at debridement. And we're using ICG-based perfusion imaging, which I'll talk about in a little bit. But we all know, we've talked a lot about how important debridement is, and it's because we need adequate blood flow to bone so that antibiotics can be delivered there, immune cells can be delivered there, growth factors. Nothing will heal if the bone is dead, and the infection won't go away when the bone is dead. And we've talked a bit already about how much of an art this is. So judging the thoroughness of debridement is really based on surgeon experience. So there are things like the paprika sign, you burr, but I can't tell you how many times I've stood in the operating room, I burr some bone and I squirt some saline on, and I'm like, is it bleeding? Is it not bleeding? It's not like a yes, no experience in the operating room. And so I would argue that we currently don't have any good objective tools. And so we're working to develop some tools to measure bone perfusion quantitatively and accurately in ways that can be visualized in the operating room in real time. And so this is an infected non-union patient from a partner of mine. And you can tell that there's not a tourniquet out. This bone just looks dead. But aside from pulling out a burr and burring back until it's bleeding, we don't really have a good way to quantify this or understand how much needs to be debrided. And we ideally really want to be precise about this, because if we debride too little, we think the infection won't get better. It's going to come back. But if we debride too much, we make our reconstructive challenges harder. So if we can really optimize this, it would be good for us and for patients. And so we've begun to apply ICG-based perfusion imaging to help orthopedic surgeons see things in the operating room that you can't see with your eyes or feel with your hands, is kind of the principle of surgical guidance. And so this is a study where we enrolled patients who were undergoing below the knee amputation, and we were able to take a couple of extra steps before we did the amputation. And so this is a model, this is baseline imaging. So as healthy as it gets, although we know that our amputation patients are not, they don't have healthy bone. We made an osteotomy and then we stripped the periosteum off. So in the osteotomy stage, we think we disrupt endosteal blood flow. And in this stage, in this third stage, we disrupt the periosteal and endosteal blood flow. And what you see in these max fluorescence imaging heat maps is that across these three clinical scenarios that are similar to kind of like a controlled version of what we see in a fracture, that the perfusion definitely goes down predominantly, especially distally in the osteotomy, and then both proximally and distally after you strip the periosteum off. And I have these kinetic curves down here just to suggest that it's not only the maximum intensity that changes, it's actually the shape of the curve. And so that reflects the inflow outflow parameters of the bone. And so we know from flaps that venous outflow is really the problem when flaps go down. And so, you know, we can measure things like venous outflow from bone, which may be a problem here as well. And so this is just the variables we're able to measure. I talked about the maximum intensity. The ingress slope is here. This is related to the inflow or the arterial flow, and the egress slope is related to the venous outflow. And so this is some of the image maps that you can see in the operating room. This top one is an IMAX overlay, so maximum intensity overlaid over the white light image. This is just maximum intensity, and this is ingress slope. And we can show kind of all of these different parameters on a heat map in the operating room. And you can imagine a universe where if we understood the quantitative relevance of this better, it could really help us do a better job debriding. And, you know, in our interim analysis of the clinical trials we're running, it turns out that low perfusion area, not surprisingly, matters a lot. And so this purple is circling the low perfusion area on this heat map on the right. And this other heat map on the right in this lower column, on this lower row. And not surprisingly, this patient with a bigger low perfusion area is the one that failed and got recurrently infected. And so this is the Kaplan-Meier survival analysis of our interim results, and it's pretty exciting, it's pretty interesting, but it turns out that if you have a large low perfusion area, you're likely to fail within 3 months, which is not surprisingly in retrospect. It kind of confirms what we think we already know, but it also shows us that this tool is pretty sensitive in a way that our eyeballs are not, because these surgeries were done by trauma surgeons who are kind of experienced at doing this. And we still left enough dead bone that failed at 3 months in the post-debridement images. And this is just to show some other things that we're working on in terms of intraoperative visualization. So if we know thresholds that are important, having sort of this traffic light, red, yellow, green image would really be helpful in giving us a sense of what needs to go in the trash and what can stay. Just take-home messages from this work is we know this really quantitatively shows us that a good debridement of this poorly perfused bone really does matter in a way that we haven't been able to, we say this a lot, but we haven't actually been able to quantitatively show that in the past. It seems clear that these bigger low perfusion areas are associated with early recurrent infection. And we're working on making these intraoperative fluorescence imaging strategies available. We're using a device that is currently available. Most plastic surgeons have SPY-FI or SPY Elites in their operating room. And so we're working on tailoring the software so that it gives us images that will be actually helpful for us to apply those same tools that we already own to orthopedic surgery. And I apologize if I spoke quickly.
That's great, Leah. While Arun stop sharing. While Arun spins up his slides, how long till this is ready for prime time? How many years away do you think you'll be able to have something where we actually can use it in the OR?
Yeah, I mean, you could use a SPY in the OR now, but the images that the machine will produce for you are not going to be that helpful. And so some of the images, the heat maps that I was showing you are still a couple years down the line, but not like a decade or two. It's, you know, these are FDA approved devices and the ICG is FDA approved. And it's really a matter of optimizing the data interpretation rather than, you know, creating a new imaging device or anything.
Thank you. Go ahead, Arun. Let's hear about local antibiotics. You're muted.
All right, sorry. Yeah. So I'm going to speak about local antibiotics. This is a topic near and dear to my heart. I originally got my research start looking at drug delivery systems, and it was for infections. And the more I did it, like, we looked at calcium sulfate, we looked at tricalcium phosphate, all these different carriers. And what it really turned out to be was, as long as you got the drug there or the antibiotic there, that's what really mattered. So let me give you a quick outline of all the talks we're going to talk about, or all the studies, the randomized clinical trials that are underway and some that are down the pipeline. And where we're sort of heading with that. I think it's going to be a pretty exciting future. So the first is the Vanco trial. So obviously we kind of know the results. This was Dr. O'Toole and his group with the metric, looking at vancomycin powder. Again, keep in mind they did it for high-risk tibial plateaus and pilons in about 980 patients. It was a randomized clinical trial, great level of evidence. And what they found was a reduction in gram-positive deep surgical site infections. So this was published in JAMA Surgery. So the same group, though, they wanted to now target gram-negative bacteria. And so now they're doing another metric study called the TOBRA that's comparing VANC versus VANC plus TOBRA. Again, in the same subset of patient population, high-risk tibial plateaus and pilons, the outcomes are still the same about deep surgical site infections, and the results are pending. And I'm kind of excited and looking forward to those results coming. Another study that we are doing, this is another randomized clinical trial that is looking at aqueous tobramycin for fracture-related infections. We've done some preliminary work showing that tobramycin can be well targeted at certain dosages against Staph aureus. So we're delivering about 2 milligrams per mil. We're doing this as a randomized clinical trial. Again, with 2 centers, outcomes are fracture-related infections as well as union status and speciation. And right now we're at about 450. And so I think in the next year, we should be very much completed, and look forward to sharing the results. I can tell you this study came from one of my mentors at University of North Carolina, Dr. Lori Donners, who did this same study, except he did it in a retrospective fashion, where he had 352 open extremity fractures, about 180 in one group and 168 in the other. And one group was the standard of care for these open fractures, and the other one got aminoglycosides. It originally started with gentamicin, and then they found that tobramycin was much safer, and so converted that. And they saw a significant reduction in deep surgical site infections with no impact on union. And so that's what was really the impetus for this prospective randomized clinical trial. I can tell you that we've done similar retrospective studies since implementing this, and it's been efficacious, though the sample size hasn't been as large. This is another good one that many people might not have heard about. It's called the powder trial. So now the thought is, how about giving antibiotics sooner? LAC and the Charlotte Medical Center group put out data on timing of IV antibiotics as being extremely important. The 66 minutes rule came about. And so this group of emergency medicine physicians came up with the idea of giving 2 grams of vancomycin powder in the ED and comparing that to the standard care. And this is for all open fractures, humerus, radius, ulna, femurs, tibias. 200 per group. Outcomes, deep surgical site infections that require return back to the OR in one year, and the results for that will be pending. So that prompted us also to put out another study, again, which results as well as funding are going to be pending. And this is actually with the AO group and Dr. Bremski, where we're actually now looking at a different carrier. A lot of concern with some of these local antibiotics is we don't know how long it stays in the environment before it gets cleaned out. So now we're back to a different drug delivery system, in this case, hydrogel, something that's dissolvable. It doesn't have that chalky white exudate, the calcium sulfate beads that Dr. Serkin was talking about. And so the whole idea is to give sustained delivery of antibiotics. And this is going to be studying about 250 articular tibia fractures, and the outcomes as well as results and funding are pending. And then finally, the last thing. So now we kind of know what VANC does. So we thought about the whole idea is to get these local antibiotics earlier to the patient as soon as they present with the open fractures. The whole thought is, the idea is that, particularly for the wounded warriors in the military. A lot of these grants are being funded by the Department of Defense. So the whole idea is that maybe the medics in the field should be carrying antibiotic powder. And as soon as the blast injury happens to the patient, maybe they should be delivering that powder. And could that really have an impact, long-term impact, on the patient's infection rates? And so that prompted us to do a similar study in the ED, except now we're using tobramycin instead of vancomycin. And again, the results and funding for this are pending. So the take-home message for all these local IV antibiotic studies is that, systemic IV antibiotics, particularly in a traumatized tissue, has very limited ability to reach MIC concentrations in the open fractures. And so that's where these local antibiotic therapy really come into play. We've seen that it works with vancomycin against gram-positive bacteria. Now the question is, with tobramycin, are we going to see benefit in all bacteria, gram-positive and gram-negative, whether that's added with vancomycin? So I think there's a lot of exciting stuff coming down the pipeline, and hopefully we'll see some good, promising results. Thank you.
Thanks, Arun. So what we're learning from this is the best way to treat an infection is to avoid it. So I think that's critical. We're going to move on now to the demonstration portion, and this is this will be a video on how to use and put together the RIA 2.
Hello, we're here today to discuss the RIA 2, the Reamer Irrigator Aspirator. This is the second version of the RIA, and we're going to discuss how to put it together and how to use it for both bone harvesting as well as intramedullary debridement. What you see in front of me is the kit and how it comes, where your operating room personnel can open it. So inside of this kit is all of the disposable components for the RIA 2. Your staff will open it up. They will take out the reaming shaft. We will take out the yellow drive seals that are used to go inside of the RIA, and I'm going to show you how to put all of these together. And then on the bottom includes your collecting canister, your irrigation tube, and your aspiration tube. So this will be all opened and placed on your sterile field. So now we've opened up our disposables on the field. We have our RIA tubing, we have our suction and our irrigation tubing and our collection canister, and we have the yellow drive seals that go inside of the RIA, and I'll show you how to do that. These go in the drive shaft. In addition, we've opened up the non-disposable tray. And inside the non-disposable tray, we see our drive shafts. We have 2 of them. Okay. We have a ruler, which can be used for measuring length, as well as diameter when choosing what diameter RIA tip you would like to use. We have some guide pins that can be used for gaining starting portals with an opening reamer for a tibia, as well as an opening reamer for a femur, and an awl that can also be used. The only thing we don't see here that we haven't opened up yet is our beaded tip guide wire for the actual RIA and when you're doing your reaming, which can be opened and placed on the field as well. In addition to that, we have a T-handle for your guide wire, and we have this device here, which is we can show you how to use, which is to remove the RIA head off of the reaming drive shaft. In addition, there is this piece, which I will show you how to use. This is to use to get your graft out. Okay, so let's start assembling the RIA. The first thing you'll notice is that there are sterile directions that you can use if you're not sure how to do it. Okay, let me now start with a reaming tube. And you'll see this is the reaming tube. It's hollow. And that's where your drive shaft is going to go into. In addition, if you focus down on these 2 areas, there's a smaller input and one large output. And it says irrigation. The I is for irrigation. I'm not sure if you can see that, but there's an I on there. And there's an A here. So this is where your irrigation comes in and where your aspiration goes out. So the first thing we're going to do is take the yellow rod seals and open the package. These have been placed on the field sterilely in case you drop one. And we're going to place them into our drive shaft in the following manner. Okay, so there's a hole here. It can go in from either side. And this pushes in, and this will stop fluid from coming back up your rhea shaft. This replaces the old rod seal that went on the end of the drive shaft from the rhea 1. The next step is to go ahead and place your drive shaft into your rhea. Okay? And it gets a little firm, and then you push it, and you'll hear it click into place so that it's now in place. The next thing you're going to do, if you're doing an infection and you want to do a debridement, you choose a reamer head size 1 to 2 millimeters larger than the intramedullary nail came out. If you're doing this for a bone graft, you're going to take this sizing ruler, lay it over the diaphysis of the smallest part of the isthmus, and by using one of these, you can choose the size rhea head that you would like to use to collect your bone graft. Again, typically 1 to 2 millimeters of the narrowest diameter of the intramedullary canal so that you get good quality bone graft. Now we've selected our reamer head. The reamer head will become like this. You'll choose it. These are sterilely wrapped. Your operating room personnel will then open them up and place them onto the field for use sterilely. And that's how your tip will appear. A lot of times your scrub techs will try to be helpful, and they'll open this for you, and they'll go ahead and take the reamer tip out of the box for you and out of the plastic. This is not a good idea, and what you should do is you should maintain this and save this plastic to protect your fingers, as these reamers are sharp, so that when you insert your tip into the rhea drive shaft, you can protect your fingers so you don't cut yourself. So now you go to the end of the drive shaft, and this simply pushes on until you feel a snap. And now your drive shaft is on and secure. The next step, so now we have our rhea tube with our drive shaft inside and our rhea tip connected, and now we need to connect our suction as well as our irrigation. This came sterile in our set. So the next thing we have to do is connect our aspiration tubing and our irrigation tubing. Well, we're going to do collection here because this is for an infection case. And so we're going to take our collection canister, which has this quick connect, and we're going to attach this directly to our rhea shaft. The next thing we're going to do is take our red aspiration tubing, also with a quick connect, attach this quick connect to the bottom of our collection canister, and throw the rest of the tubing off the field for connection to your Neptune or whatever suction device you have. Next, we're going to take our irrigation tubing, which is blue, and we're going to connect the one end of it without the spike to our irrigation port, and then pass the rest of the tubing off the field so that we can spike a bag. And this will be the setup. So we have our rhea setup, our irrigation fluid, our aspiration, our collection canister, and the other parts going off the field. And the last part is to go ahead and connect your drill. In this case, we're going to connect the rhea with a Jacobs truck, but also you could have a modified trinkle attachment that should be in the set. So we're going ahead and attach this. Tighten it. And now we're ready to begin RIA. We use one of our opening reamers for any to open the canal, place a guide wire down in a typical fashion, and then we go ahead and we do our reaming over our guide wire. When using the reamer irrigator aspirator, an in and out motion is done in order to allow the tube to clear of the reamed contents, whether it be bone or debrided material. Now we have to disassemble everything. So there is a tool here that can be used to take off your reamer tip by sliding it in and just pulling. And if you pull this off, it'll come off. And then you have your RIA tip. An alternative method to removing this is just by using the drill that's still connected to the drive shaft. So to get the drill out, there's an indent on this side right here, this blue. Can you see that? Okay. And this is meant to push in to release your drill. We'll do that again. You push in to release your drill, and then as you pull this out, with the drill still attached, the reamer tip comes off as such. Make sure you do this over the table so that you can save your tip. Additionally, now what you can do, as you continue to remove the rest of your drive shaft, you can still now use your entire RIA if you want to irrigate out the canal by placing your hand over the top like this. And now you have an intramedullary irrigator as well. So now we're done with our debridement, or we're done with our collection of our bone graft. We're going to remove the drive shaft from the RIA. Again, we're going to push this button in up top and pull it out. The tip will detach as I showed you earlier. And now what we want to do is we want to take our bone graft or debridement material and we need to collect it. So we unscrew this. And now we have this collecting canister. The whole thing can come out, okay? Alternatively, you just start pulling out the white portion. And once you get it up just a little bit, you'll see there's a gap that we can form. I showed you this piece earlier that was used to collect and for bone graft. This will slide in to the canister. You put pressure and hold this, and as you lift up, it will compress your bone graft and squeeze all the excess liquid out. You then can take your bone graft out and put it in your collection, and now mix it however you want with whatever other materials. You can also take some of it for biopsy if you were doing a debridement. Here you can see we are taking some of the debrided intramedullary bone and membrane and sending them for cultures.
Sorry about that. So that's how to use the RIA. I just want to finish things up now. We've answered some of your questions. I want to remind everyone about the two upcoming webinars next month and the following month on Tuesdays, and on Wednesday, November 8th, there'll be another webinar. This is the QR code to go to the AO Trauma North America YouTube channel, where things like this webinar will be up, as well as many surgical dissections and other useful other useful YouTube videos that you may want to use. In addition, this is the QR code for the video on how to make an antibiotic rod over an Alizarov threaded rod. I would encourage everybody to please go ahead and do their evaluations, make any comments you want. We would appreciate them. And I want to thank everybody for their attendance.